Good day, friends, and a warm welcome to this episode of 4D, which is Detailed Discussion and Dialogue in Diabetes, in Indian Diabetes. This is season 3.0 going on, and we are going strong. When we speak of 4D, that is Detailed Discussion and Dialogue in Diabetes, we are reminded of another D, which is vitamin D. And when we think of vitamin D, we think of the Nobel Prizes, we think of people who did research, but let's go back in time. And let's go back to the Konark temple. Now suddenly we think, what does the Konark temple have to do with vitamin D? And then what does that have to do with our topic for today, which is heart failure? Where do the guidelines converge? Let's ask our experts about this. So a warm welcome, first of all, to Dr. Jatin Maji, Dr. Dev Prasad and Dr. Gyan. Good day, friends, and a warm welcome. Please allow me to introduce our guests for today. A warm welcome to Dr. Jatin Maji, endocrinologist at Bhubaneswar. A question from Dr. Sunil Kota in Berhampur, Dr. Jatin. What is it that you like best about endocrinology?
Actually, endocrinology, everything about endocrinology. I mean, from starting from childhood to pediatric to geriatric, everything deals with endocrinology from starting. In pediatrics also we see CH cases, emergencies, everything is inside the endocrinology. But the best thing in endocrinology is all the things are curable actually. We cure the diseases. We don't linger up we have every drugs curative diseases. Means if you have CH, you give steroids. If you have diabetic, you give anti-diabetic. If you have other things, hypothyroidism, you just supplement with a drug, and everything cure we have available, and our prognosis is also very good for the patient. That's why I like endocrinology.
Thank you so much. We'd also like to welcome our second speaker, Dr. Dev Prasad Kar, who's a nephrologist at IMS SUM in Bhubaneswar. Warm welcome, Dr. Dev.
Thank you, sir.
And Dr. Dev, this question for you, though it is a slightly naughty question, this comes from Professor Manisha Sahai, who is Professor and Head of Nephrology at Osmania in Hyderabad. And her question is, Dr. Dev, which kidney do you like better, the left one or the right one?
Which is better? Both the kidneys are better if they are working properly.
Together. Okay, that's fine. And I'm sure Professor Manisha will be very happy with that answer. She will be satisfied. Life is much easier for our third speaker, Dr. Gyan Ranjan Naik. He is a cardiologist and everybody has only one heart. So Dr. Naik, warm welcome. Dr. Naik is a cardiologist at Bhubaneswar. So Dr. Gyan, now there are two questions for you. See the googly. The first question is, are you happy that there is only one heart? Because otherwise you would have been asked a question like Dr. Dev was asked. Are you happy with that?
I'm absolutely happy. We are already fatigued with one heart. I don't want another heart.
But now comes the googly. And this is from Dr. Abhay Sahu, who is a senior endocrinologist in Bhubaneswar. Dr. Abhay has this question for you, Gyan. He says, as far as I know, you can give your kidney to only one person. But you can give your heart to as many people as you want. So his question is, Dr. Naik, would you want to tell us about your undergraduate days and cardiac sharing? Or would you not want to tell us? What is this question?
So actually, I'm sitting in my home. Rather, I would not discuss all those things.
Let's come to more serious matters and let's come back to what we were talking about in 4D. Let's talk about how things converge, the heart, the kidney, and the endocrine system, and let's see how we can help our patients. Dr. Jatin, the Konark temple is famous across the world, actually, not just across India. So, how does the Konark temple remind you of vitamin D? And what does this have to do with your work as an endocrinologist?
Sir, actually it is a sun temple. Sun rays directly the first rays of sun directly fall on the ideal present there. So it shows how important the sun rays is for means the gods, for human being, everything. So that's how you can relate that sun rays is essential for us to synthesize vitamin D.
And actually, the Konark temple was built where Lord Krishna's son, Lord Krishna, cursed him with a skin disease, which was leprosy. So the son went and prayed there for 12 years. And through sunlight, I guess, he recovered from leprosy. And the same treatment, when it was
Yes.
done for tuberculosis, that got a Nobel Prize, but perhaps in the Konark Temple time, there was no Nobel Prize. So, Dr. Dev, nephrology, endocrinology, all these subjects, cardiology, they are all similar to each other. When the endocrinologist or physician thinks of vitamin D, he thinks of a nutrient. He thinks of something to do with diet and sunlight. But is vitamin D actually a kidney hormone?
Yes, sir. The active form of vitamin D is synthesized in kidney only. And when there is a kidney disease, there is the decreased function of the kidney, the vitamin D level decreases. And that where it starts the CKD and BD, that is mineral bone disease of the CKD, which causes the causes bone to become weak, and the resorption of the bone happens. So in that case, we need the vitamin D therapy, that is active form of vitamin D needed at that time. And that is a very crucial part of our therapy to manage the CKD and BD.
So suddenly we see how everything converges, and all of us physicians from across India gathered. Now we are realizing the same vitamin D, you can look at it in different ways. The nutritionist, the endocrinologist, the nephrologist, all will look at it in a different way. And when you think of it from a spiritual perspective or from an architectural perspective, even then vitamin D is important. Just spare a moment to praise the people who built the Konark temple, keeping vitamin D in mind, keeping the sun god in mind. A similar thing happens today when we look at our guidelines. So, whether we are talking about diabetes or CKD or heart failure, the guidelines are similar. They may appear different. The cardiologist may use a different language, the physician may use a different language, but we are all speaking the same language of health, of good health. So, let's talk about that. And Dr. Jatin, the word fatigability, easy fatigue. I think more than half of our OPD presents to us with easy fatigability, with tiredness. And if I were to think very carefully, it's a total of just 5 or 6 symptoms which drive the clinics, the OPDs throughout the entire country. One of them is easy fatigability. So when someone comes to you with that, what are the first few differentials that come to mind?
So easy fatigability is a most common complaint that patient do to us. But we see basically we are from a coastal belt where iron deficiency anemia is very common, and anemia, vitamin D deficiency, other if diabetic, whether uncontrolled sugar, or he's having chronic kidney disease or hypothyroidism. Those are things we take into mind and we evaluate those. And chronic diseases, chronic long-standing diseases, we rule out.
One such chronic disease is chronic kidney disease. So, Dr. Deb, in your OPD, and perhaps you would like to share experience from your fellowship days, your residency, and now that you are working in Bhubaneswar, what is the percentage of people who present to you with fatigability? And from a CKD perspective, what are the common causes?
Sir, my majority means around 90% of the patients present with EB fatigability. In CKD, the causes are anemia, which may be due to CKD, anemia of kidney disease, iron deficiency anemia, or there may be because of fluid overload. The patient becomes fluid overload, then there is pulmonary edema, and the patient is unable to start, unable to walk and unable to breathe comfortably. And other causes are decreased appetite, decreased intake, and nausea and vomiting. This electrolytemia, all these cause easy fatigue in CKD patient, and which is a very common symptom in our CKD patients.
And how frequently do you experience, Dr. Jatin, that the patient comes to you? You are running a general medicine clinic and endocrinology clinic. And how frequent is it that you have to refer to the nephrologist or the cardiologist? That you say, Madam, I hear you, you have easy fatigability, you do have thyroid, you do have diabetes, but actually you need to go to the cardiologist.
Actually, cardiology evaluation we do in easy fatigability. Maybe 10 to 20% of the cases, those who are having we refer them any ECG abnormality, or we do a routine echo also. for easy fatigability we found any diastolic dysfunction or any underlying cardiac disease, we refer them to cardiologists. I think it will be around 10 to 20% cases those we refer to cardiologist OP.
And that is quite significant, which means that we need to have a fair idea of all the specialties, especially when we are in internal medicine. Dr. Gyan Ranjan Naik. Dr. Naik looks after the cardiology clinic at IMS SUM in Bhubaneswar. So, Dr. Naik, we were talking about fatigability. And when I was a medical student, heart failure was defined as a state of easy fatigability. Is that still true from a symptom perspective?
Yeah, it's still true, but in the today's era, we have to just AG fatigability. Most of the time, we overlook this symptom because in India, as you know, it's a frequent anemia belt. So most of the patients who are anemic, they will also complain of EG fatigability, right? So if the patient tells us EG fatigability, we straight away don't jump into cardiac disease or heart failure, which should be associated with other symptoms. Then only we evaluate for heart failure symptoms like breathlessness, dyspnea and exertion or orthopnea, PND associated with EG fatigability. So yes, we go for screening for heart failure diseases.
One comment coming from the audience from respected our teacher, Professor A.K. Das from Pondicherry, and he says that he feels so happy. These are Dr. Das's words. He says, "My heart feels warm seeing that our specialists of today are so grounded." In Haryani, if I were to speak, Dr. Nayak, Dr. Jatin, Dr. Deba, it would be that both your feet are on the ground. And this is praise actually. So what we are getting from all our experts is the same language. Somebody comes to you with easy fatigability. First think of nutrition, think of medical causes. After that, you think of endocrine or renal or cardiac causes. And you see everybody speaking the same language. And again, that brings us back to the Konark temple, the Sun temple. You can look at it through different ways. When you see the architecture of the Konark temple, different people will get different ideas. Some will get endocrine ideas, others will get meta-endocrine ideas. But still, the language is the same, or the concept is the same. You need holistic health. You need health in every dimension of life. So let's come back to our topic now. Heart failure, CKD and diabetes, how the guidelines converge. So Dr. Jatin, is it possible that someone with diabetes comes to you with edema, right? Is it possible that the patient has only a cardiac cause of edema, only renal cause of edema, or usually it is multifactorial? How does it work out in your clinic? Do you remember the last patient that you saw with edema?
Sir, edema usually, when we evaluate edema, the most common cause in diabetes, when there is long-standing diabetes and they are complaining of edema, after ruling out all other causes, hypothyroidism, other nutritional causes, anemia, then if we find any heart failure or any CKD, then we find that they're all associated. If one is having CKD, is having some cardiac morbidity also, and if there is cardiac problem, he is having a partial CKD also. So the three diseases, uncontrolled hyperglycemia, CKD, cardiac disease, all are they are intermingled and they are associated. So we cannot CKD, we should give also cardiac protection. If we are treating for cardiac disease, we should give renal protection. So we should have a holistic approach to these patients.
This is well taken. And Dr. Dev, one of your colleagues from New Delhi, Dr. Saurabh Sharma, he says, do your patients ask you in Odisha, sir, is my left kidney spoiled or is my right kidney abnormal? Or they just listen quietly to what you have to say and they take the treatment quietly?
No. I mean, most of the patients, they have a lot of doubt on whether their left kidney is working or right kidney is working totally, which one is damaged, what percentage is damaged. And I have to explain everything from the beginning, that you have two kidneys, when both start, the damage starts in both the kidneys, then only the creatine rises and you have all the symptoms. So initially, at the means around 8 years back when I started first started practicing and joined some hospital, I got patients who came with edema. Most of the patients they were referred from endocrinology or cardiology after or a medicine medicine department medicine OPD because initially because of edema they have opposed the medicine OPD or cardiology OPD or other OPDs. So whenever when they got diagnosed, they are that the creatinine is increased, that they have CKD or there is kidney kidney dysfunction, they are referred to nephrology clinic. But nowadays, I got a lot of patients from even villages. Whenever the edema arises, they have now they can imagine that they may have some kidney disease, and most of the many of the patients they come. I am sir, my legs are very and I think I have some kidney disease. Please do some tests for the kidney disease. So the awareness of the kidney disease has rose in this in nowadays, and even the common people they have some ideas how what are the initial symptoms of the kidney disease.
This is also very pleasant news, and I think most of our listeners across India will agree with this, that awareness is going up. Now, sometimes we get irritated and we criticize our patients. You know, he is a Google Baba, he is a WhatsApp doctor, and you get irritated at left and right. But please don't do that. Why can't you feel happy?
No,
Why can't you feel yes? So you tell, thank you, left kidney, right kidney, you are working hard. So, and EGFR, if you take normal EGFR is 100 roughly, then the EGFR is a very easy. Yes, your kidney is working 40%, your kidney is working 20%. So even if
yes,
somebody
yes,
has got an EGFR of 24, you don't say that your kidney is spoiled by 70% or 80%. That is a very negative sounding sentence. You just say your kidney is still working 24%, doesn't matter, we will maintain it at that. And that is the way.
yes,
Dr. Gyan, can you help us? And I have always struggled with this as a physician. Somebody coming to me with edema. So there is swelling in the legs. Somebody coming with pulmonary edema, there is swelling in the lungs, or there is water in the lungs. How do I figure out which patient has got predominantly cardiac disease and which patient has got predominantly non-cardiac or renal disease? What are the pointers from a cardiology perspective? And if you could do from history, examination, and investigations.
That's a very clinical oriented question, which is actually a very good question, because if the patient comes to us with edema, so if I am thinking about cardiac involvement in that, so it could be either a right heart failure or a biventricular failure. So if it is per se only pulmonary edema, so it is actually a left heart failure. And we know the common cause of your pedal edema per se for a cardiac point of view is a right heart failure due to left heart failure. So the most common cause of right heart failure is in fact left heart failure. There are very rare diseases which are isolated right heart failure, which will cause pedal edema and your hepatomegaly, like ARVD or right-sided cardiomyopathies. But most of them are left-sided heart disease, whether it could be your dilated cardiomyopathies, ischemic cardiomyopathy, or mitral valve diseases, which will eventually start with your left-sided heart failure, then going into right-sided heart failure. So if you have a edema, whether the patient is cardiac or non-cardiac, so it could be told by looking at other clinical signs. First, history is very important. So if is the edema is associated with dyspnea and exertion, prior history of paroxysmal nocturnal dyspnea or PNDs, and now gradually orthopnias. If the patient has EG fatigability, is the patient had an history of prior chest pain or myocardial infarction or a treated coronary artery disease, now going into ischemic cardiomyopathy? Is the patient uh, having frequent, the patient is not able to sleep in the night, and he is waking up frequently with nocturnal cough and dyspnea. So all these are pointers. Apart from them, that there are some clinical pointers, like if there is fine crepitations in the basal area of lungs and the JBP is raised, you have LVS3 or cardiomegaly in the palpation, then without doing any further investigations, we can tell that the edema is cardiac or non-cardiac. Though we have lot of modalities today, we have NT-proBNP, we have 2D echo and all these facilities, but in the bedside or in the OPD patients who come to you with edema, you can always rule out other causes of edema from cardiac edema.
Clinical skills are important, and if you just keep on practicing them, the more you practice, the better you become. Dr. Jatin, any endocrine causes of edema? So usually the textbook says Harrison will teach all the etiologies separately, but that doesn't mean the patient can't read 2 chapters and come with 2 etiologies together. So it might be heart failure and CKD. It might be either of them, but it also might be other things added, isn't it? So any common endocrine factors or nutritional factors which cause edema?
Nutritional factor, as we know, iron deficiency anemia, it may cause edema. And endocrine cause, mostly we deal with hypothyroidism. It is the most important cause of pedal edema that we get. Another cause of any fluid overload or those cardiac and diabetes, DKD, diabetes, kidney disease.
These are also common, and in my practice, some of the things that I see are very simple things. Low protein diet, which is rampant in Northwest India. Low protein diet itself will cause some amount of edema, and high salt intake, especially in winter here. Our patients take high salt containing foods and beverages. One of our favorite is fermented carrot juice, which is known as kokum. So, which is known as a kanji. Kokum is from Goa. So when they take kanji, that is so much of concentrated salt that leads to fluid retention, and it plays havoc with our CKD patients also because they get in trouble with their electrolytes as well. These are some reasons that we try to rule out in the OPD. And another reason is premenstrual syndrome.
So in our mostly they restrict their salt.
Yes. So if they slip, sometimes they make a mistake, then they get in trouble. And premenstrual syndrome also we should rule out. So you take a history of cyclic edema, and it might be a very simple cause that comes. But we've been speaking so much about problems only, and what about solutions? If our language is the same when we are addressing these problems, should our language be the same when it comes to choice of drugs? So, Dr. Dev, if we could start with you, SGLT2 inhibitors, how frequently are they used in nephrology practice? Are they preventive, promotive, curative? How does the nephrologist view SGLT2 inhibitors like dapagliflozin?
Yes, sir. Now, as the DAPA CKD trial already and DAPA CKD trial already we have seen that the dapagliflozin is not only effective in diabetic nephropathy but also in non-diabetic kidney disease also. So we already have, all the nephrologists already have started using dapagliflozin or empagliflozin as in patients of non-diabetic kidney disease, because it has shown effects in reducing the proteinuria, reducing the rate of progression, it reduces glomerular hypertension, so it reduces glomerular injury. Even it has also effects on the inflammatory, and it has some anti-inflammatory and anti-fibrotic properties. So overall, this has a very good effect even in non-diabetic patients in reducing the rate of progression of the kidney disease, as well as in diabetes. It has it has a glucose lowering effect, and that secondarily leads to decreased kidney damage and the prevents the progression of the diabetic nephropathy. So nowadays, even in the Clinical guidelines, they have added this inhibitors as both recently and in diabetes and non-diabetic diseases, and they are now regularly being used in kidney disease. Up to the
So,
year of 20, we are using dapagliflozin as a preventive treatment for the that is to reduce the progression of the disease in CKD in both
so
diabetes and
dapagliflozin,
non-diabetic.
yeah. Dapagliflozin is a pillar of management for CKD, both diabetic and non-diabetic kidney disease. Is the same true, Dr. Gyan Ranjan, for cardiology? How does the
Yes,
cardiologist view an SGLT2 inhibitor like DAPA?
yes, sir. In the era of evidence-based practice, we know that after the advent of the SGLT2 inhibitors, now through various trials, as Dr. Deva Prasad has told, DAPA CKD, we have the DAPA HF trial, and all these trials have clearly shown significant benefit, not only of heart failure hospitalization, but also with all-cause mortality has decreased. So, the SGLT2 not only decreases the cardiovascular mortality in heart failure with reduced ejection fraction, but now the guidelines have clearly shown in the heart failure with preserved ejection fraction. So any coronary artery disease, whether it is diabetic or non-diabetic, the guidelines say class 1 indication. So it's class 1 for any coronary artery disease. So if we are doing a stenting or a CABG, so after that, the SGLT2 inhibitor, whether DAPA or EMPA, is given to to prevent heart failure hospitalization and long-term mortality is significantly decreased due to all these pleiotropic actions which he has told. So in our practice, for heart failure with reduced ejection fraction, it was previously known, but as you already know that in heart failure with preserved ejection fraction, we have very limited amount of resources, as all the drugs, the pillars like the ARNI, ACE inhibitor, beta blocker has shown no benefit. Only the SGLT2 and now some Finrinon has showed increased benefit in heart failure with preserved ejection fraction. So yes, SGLT2 is a cornerstone of the management in all cardiovascular patients in association with the kidney disease.
So we see that the guidelines are converging. For diabetes, of course, dapagliflozin was always drug of choice, at least for the last 1 decade. Same is true for kidney disease and cardiology, and there also the indications are expanding. But Dr. Jatin, another class of drugs that we are speaking about now is GLP-1 receptor analogs. So in just a few sentences, could you suggest the indications for GLP-1 receptor analogs from an endocrinology or diabetes perspective, just purely diabetes and endocrinology?
The GLP-1 analog has now come into the picture in a great way, sir. It is one of the four pillars, the main pillars of diabetes kidney disease, what we are using. If the patient is having obese or even if non-obese diabetes also, we are relying GLP-1 analogs, and it is renoprotective. It has proven that in many studies that it reduces proteinuria, and also EGFR increase meant also improvement is also seen with GLP-1 analog. So GLP-1 analog now, although approved issue is there, but it is a cornerstone of management in diabetes kidney disease, and we are after SGLT2 inhibitor. I think it will be the most appropriate therapy for diabetes kidney disease in diabetes.
And let's take this discussion to nephrology then. Dr. Dev, so I speak from old times when I was a student, and most of my MD and part of my senior residency was done in nephrology units. But the kind of patients that we used to see at that time were totally different from what we see now. Now, when you see patients who are on RRT, renal replacement therapy, they look good. You are able to take good care of them. Earlier, all of them would be frail, very weak, sarcopenic, and just counting their days and weeks and months. It used to be a very pathetic state of affairs around 30 years ago. Now things have improved. So, do you feel that the CKD patient, the person with stable CKD, can take GLP-1 RA, and do you think it will help them?
Yes, sir. In CKD patients, not in RRT, there is a trial, that is pro trial, which have shown that it reduces proteinuria and helps in decreasing the progression of kidney disease. But till now, not a lot of studies have come. So it is not being rapidly used, but sometimes we use these GLP-1 analogs. And these RRT patients, probably they are only used for controlling the sugar, blood sugar, because as already the kidney disease has progressed to an end stage, so there is no going further, so it doesn't have to prevent anything. So it is only used for sugar control in RRT patients, and in CKD patients in stage 3, stage 4, we can use, but although there are very few studies which have shown that it reduces proteinuria and reduces the progression of kidney disease.
And theoretically, actually, theoretically, you can use semaglutide up till eGFR of 0. Though practically we would like to stop at 15. And the main issue would be frailty, actually, and GI tolerance. But otherwise, these newer drugs can be used, and from a purely glomerular perspective, they will help the patient. Dr. Gyan, obesity is such an issue, and now we are speaking about the obese heart, the way obesity impacts the myocardium, the pericardium, and then these concepts were not there a few decades ago. Fatty pericardium, fatty epicardium, fatty heart. So how common are these? When you are doing an echo, can you see fat on the screen?
Yeah, of course.
Now,
Of course. So
tell us about
During echo, mostly in the females, fatty females, we can clearly see epicardial fat. So that is a marker of insulin resistance. It's visceral adiposity. So during 2D echo, we can clearly see a layer of epicardial fat, which looks kind of effusion, but the refractile index is little bit higher. It looks little bit of speckle pattern or a whitish type rather than pericardial effusion, which looks little bit of hypoechoic. It looks little bit of hyperechoic. So the difference is subtle, but yeah, we can see that. And mostly the obese patients, you can see it as a marker of insulin resistance. So it's along with the fatty liver and all those things, a visceral adiposity. It is a marker of visceral adiposity if we find the thing in the 2D echo. Yeah.
A request from all of us who are listening would be that when you see this, please inform the patient. Do not be judgmental. Do not be sarcastic. Do not make that person, the lady or the gentleman, feel that you are laughing at them. Just say that yes, this is there, and it is good that we have been able to pick it up. Thank you. You have got your echo in time. This is ectopic fat, and we need to give you medication. You must follow diet and exercise and take the medication so that you can dissolve this ectopic fat. So if you do that, then the adherence to therapy for the whatever therapy the physician is giving, that improves. But Dr. Gyan, what about GLP-1 RA in cardiology practice? How are you doing them?
So as you know, sir, in cardiology, in our situation, most of the patients who are having coronary artery disease, around 1/3 or more. Even now, the situation is even more grim. We are getting a lot of diabetic patients with obesity and CAD. So the incidence of insulin resistance is very high, and in those cases, GLP-1 agonist is actually a boon, I would say, because we know that insulin will increase the obesity. If we take the advice of the endocrinologist, and I think it is a very good drug. We have started using it currently, and we have used in a lot of patients, and we are getting good results. As you see, the weight loss happens all the parameters of the metabolic syndrome. The blood pressure decreases. We could able to decrease the BP medications, or the dyslipidemia improves. We can decrease the dose of statins, and you can see the effect on the patient. We can see the results.
So this we see again, we were talking about how the guidelines converge. We realized that all our speakers, Dr. Jatin from endocrinology, Dr. Debo from nephrology, and Dr. Gyan Ranjan from cardiology, all speak the same language. What I liked best was the person-centered approach, the clinical approach. Take a history, look for simple things first. Optimize nutrition, optimize lifestyle. After that, you think of specialist kind of, or not rare, of course, cardiology, nephrology diseases are not rare anymore. But first you look at the basic thing, optimize nutrition, optimize lifestyle. So that is what we have in common. And then another thing that we see is that the same drugs are used in different clinics. So as an internist, we are very well placed now to use these drugs that we have, GLP-1RA, SGLT2 inhibitors. We can use DPP4 inhibitors also, mineralocorticoid receptor antagonists. All these in quest for better health. The same way that Konark Temple symbolizes unity. 4 chariots, a big chariot with 4 pairs of wheels, and they talk about the sun god and how they are able to put things together. The same way we should be able to get things together for our patient and view that patient, treat in a holistic manner. Thank you everyone for being with us today. It's been great having you. Keep on tuning into 4D, Detailed Discussion and Dialogue in Diabetes, and we look forward to your comments, your questions, your criticism.